I'd like to move on to our next sponsor of our next panel, Victor Versnick of 7-Eleven, to introduce the session and moderator of our third panel titled Prescription for a Continuum of Care.
Thank you, Jess. On behalf of 7-Eleven Canada, I'm pleased to be here today to introduce today's panel, Prescription for a Continuum of Care. Like many of the SOS members here today, 7-Eleven is part of the fabric of communities across British Columbia with over 2,000, about 2,500 frontline workers minding the shop and dealing with a variety of issues at about 180 7-Eleven locations. And that broad provincial reach gives us really a front row seat and a line of sight in terms of what's happening with certainly our employee safety, with crime and shortage, and also addictions. And today's panel takes then a closer look at addictions and mental health and the real need for a continuum of care that stretches across from assessment through to treatment and then to recovery, and what that could mean for public safety in every BC community. So our third panel today is moderated by Carol Taylor, one of British Columbia's most recognized community leaders, and Carol currently hosts a public affairs TV program. Her background as a broadcaster, a commentator, a Vancouver City Councillor, a former Minister of Finance makes her the ideal moderator for this challenging topic. So please join me in welcoming our moderator, Carol Taylor, and her panelists.
Thank you all. We are the only ones standing between you and lunch, so we're going to be fairly swift. I did want to thank you actually so much for all of your information about Alberta. And so I don't really need to introduce Marshall anymore, but I did want to say if you want to know more about Marshall, on my show tonight, Marshall is the chief guest. And so thank you for what you had to say here and also for our interview. Joining me as well is Dr. Nicky Matthew. He's an addiction and a forensic psychiatrist. He completed an addiction psychiatry fellowship at Yale and then a forensic psychiatry fellowship at UBC, where he is currently a clinical professor. We hope that Dr. Puya Azar, he's a clinician scientist, is planning to join us, but at the moment, we're it. So, when we listened to the two panels this morning, it was very clear that whether you're talking about policing or the justice system, it was all circling around mental health and addiction. And so that's really the focus of what we have to talk about. Nicky, maybe I could ask you just to give us a few opening thoughts about how you're approaching this situation with your experience and background.
I work as a forensic psychiatrist as well as an addiction psychiatrist, and I wanted to start with a story. This was a patient of mine in forensics. His name's John Doe. When he was very young, his father left the family, and his mom essentially had to raise him in poverty. Because of the color of his skin, he faced discrimination, and so he felt a sense of belonging with some other kids who were using cannabis. And then he got addicted to opioids from hydromorphone that he bought from the street. And then due to his theft and his drug use at home, he was asked to leave home, and he went to live in the downtown east side. While he was in the downtown east side, to cope with living there and being able to stay up at night and the risk of danger, he'd use crystal meth. And then a year before his index offense, he started getting psychosis. So psychosis is a loss of touch with reality. And he started hearing voices. On the day of the index offense, he heard voices that the person in the store with him wanted to hurt him. And as a result, John Doe shouted at a stranger in the store. The stranger in the store was frightened and grabbed John Doe. John Doe felt scared for his life, pulled out a knife and stabbed the victim in the neck. Now, after John Doe was pulled into the forensic system, he was treated with antipsychotic medication. He felt a lot of remorse. But this was something that was very preventable. And so if you think about the Swiss cheese model of disaster, imagine slices of Swiss cheese spinning, and when the holes line up, something happens. And so with John Doe, this was somebody who didn't have supports when he was younger. He didn't have things to do. He didn't have a sense of belonging. There was the availability of drugs, and there was the lack of treatment. And all of these things led to the index offense. So there was a famous saying by a British historian. It was, society prepares the crime and the criminal commits it. And I think this is what ended up happening with John Doe. So the main takeaway point that I want to get across here is that in British Columbia, there's been a separation of addictions and mental health. And I think both of these need to be treated concurrently, meaning at the same time. And I think these are the kind of treatments that will lead to the best outcomes for British Columbians. So that's my introductory comments, but I'm going to get into more detail as we go on.
Well, one of the things that we had talked about before is the psychosis and the violence that I think everybody is seeing on the streets and feeling. Is there more psychosis? And if so, why do you think?
So there is more psychosis, and it's because of the increase in psychoactive drugs available. So with the legalization of cannabis, there's been an increase in cannabis use, there's been an increase in cannabis addiction, and there's also been an increase in cannabis-induced psychosis. In addition to that, we have a different kind of meth on the streets now. It started in 2006 in Canada, and it's increased since then. And this is phenyl-2-propanone meth. So in the past, they used ephedrine to make meth, and you would take one molecule of ephedrine and you could make one molecule of meth. The issue was the meth that they used to make was a racemic mixture. So imagine two chemicals that looked almost identical, but it was like your left and right hand. They're not exactly the same. So you had L-methamphetamine, which was a nasal decongestant, so it wasn't psychoactive. And then you had D-methamphetamine, which was psychoactive. When they banned ephedra, the cartels, they were able to develop a new method of making meth called phenyl-2-propanone method. And this made a pure form of meth that was mostly D-methamphetamine. So we are seeing more psychosis due to this more potent form of meth. So if you take everyone who uses meth, 40% of them will have psychosis. So that's a large number. But as the severity increases, there's a higher percentage of people that will have psychosis. So once you get to from mild to moderate to severe methamphetamine use disorder, about 100% will have psychosis. And psychosis is a big risk factor for violence. So violence in the general population is about 3%. When you take people with psychosis, it's about 9 to 12%. So it's a huge risk factor for violence. So yes, I think the increased amount of drug use and the types of drugs are leading to increase in violence.
And you, when you think about when you were first an addict and on the street and the kind of drugs that were there, do you think if these powerful drugs were out, you'd be with us today?
You know, I have a bit of, going down the rabbit hole of molecules and complexity and, all of it. I would have leave that to the smart guys to figure that out. For me, I see some different issues with this. I think that one of the realities is a lot of this psychosis that we're seeing is being caused fundamentally by the fact that we have a lot of sleep-deprived people who are out there, right? You have people who are using a lot more drugs more often. Yes, the potency of these drugs is more complicated these days. But what's different about today than when I was on these streets out here is when I was on these streets out here, I had reprieves, right? Police would arrest me and put me in jail. I would take a month off, right, to go in to get my health back, to get, my health metrics up. We don't put anybody in jail anymore. So if you're a homeless addict and you're doing 4 years of homelessness, you're doing the whole 4 years without intervention, right? And so when you're out there doing this and using drugs unintervened on like that, the amount of sleep deprivation and damage that you're doing to your brain is a huge factor in terms of psychosis. And I think is compounded, certainly as well by the supply side issue that Dr. Matthews highlighted. So
Nikki, you talk about the path that's causing more psychosis. Once you're on that path, can you get off it if you've really got into a psychotic state?
You can. So the issue is that there's a timeline issue with this, and I think I want to echo what Marshall was saying. I think these breaks are actually helpful. Substance-induced psychosis is a neurotoxic event. So what that means is almost everyone who starts using these psychoactive substances don't become psychotic. Then as they continue to use, they start to become psychotic during the intoxication phase.
right.
Then it starts to linger into the withdrawal phase. Then it starts to continue into times of sobriety. So it gets longer and longer, and it also gets more difficult to treat, and the psychosis becomes more severe. And the problem is it takes time to recover from this. So even from addiction, in the scientific literature, they call it protracted withdrawal, and in the treatment community, they'll call it a post-acute withdrawal syndrome. And so what happens is when you're continuously using these substances over time, your body loses dopamine receptors. So dopamine receptors are responsible for reward. So I'll get a bit tangential, I'll bring it back. So imagine astronauts going up into space, they lose bone and muscle mass. Why? Because your body's saying, well, if I don't have all this gravity to fight against, why do I need to spend all this energy on bone and muscle? If you're stimulating the reward centers in your brain to levels not found in nature, your body's going to say, well, why do I need all these dopamine receptors? And the acute withdrawal phase is, depending on the substance, takes about 7 to 14 days to get over. And that's not the real issue. The real issue is the post-acute withdrawal phase. So the symptoms are going to be worse 3 to 6 months into recovery. So what are the symptoms? Well, one is anhedonia. So that's a difficulty in experiencing pleasure in pleasurable activities. Then there's difficulty with concentration, and there's difficulty with sleep. And these are worse 3 to 6 months after you stop using. You don't start getting recovery until about 8 to 10 months into recovery, and when you stop using. And then you don't start reaching your pre-morbid level of functioning until 18 to 24 months. So this isn't something that can be cured in a 30-day rehabilitation facility. This is something that takes months to years to recover from. And so you need that regeneration of the dopaminergic function in the brain to recover from this and to get off this train to continued psychosis over time.
I couldn't agree more with Dr. Matthews. One of the things that we have done and need to do is, building our facilities where people go to do this requires a new way of thinking. It's long term. Right? There's all of these arguments out there about, housing, and we've got to give them, a home and treatment and supports and this, that, and thing. The answer is yes to all of it, but it all has to be rationalized into one effective model. You can't be having people all over the place, in a very disorganized way. Our new facilities are year-long programs because we know that that's what it takes to be effective. I want to treat somebody once, not 10 times. That's where we're going to get our best ROI. And even in our facilities, everything counts to the bottom line. Their diet, the no sugar, low salt, high protein, like everything has got to be like astronaut training, to get the people who need the help the most. And so that's, we've got to set up the system to respond to the reality of how much damage is being done. Look, there is no world where using these drugs is okay, safe, acceptable, beneficial, etc. I don't care what the current drug du jour is that is out there. There's always going to be something new coming out. The reality is this is not an acceptable lifestyle choice, as many in the community would have us sort of this narrative that is growing, and that our job is just to make sure people can use safely. That's bullshit, right? Snap out of it, None of these things are good, and it is not healthy, and it is going to kill you, and it will continue to kill people. So,
Dr. Matthew, you feel the same way about safe supply?
I have pretty strong opinions about safe supply that I voiced earlier. I think it stems to the definition of what harm reduction is. So I'm very pro harm reduction, but the problem is the definition that they use for the term are policies and procedures that aim to reduce harm in people who are unwilling or unable to stop using drugs, not things that have been proven to reduce harm. So the problem is they're introducing things and they're calling them harm reduction strategies when they haven't been proven to do that. So there are things that help reduce harm, like having sterile needles. It helps prevent things like hepatitis C spread, things like that. But there's a lot of things that are introduced as harm reduction, like decriminalization and the way that they did it in British Columbia. That was introduced as a harm reduction strategy, but it wasn't proven to do that. And then over time, we saw the repercussions of it. So things that have been proven to work, I think we should do. Things that have not been proven to work, we need to prove them first before we implement them.
A question from our audience says, while addiction is easy to consider as a mental health issue, it is not an excusable reason to commit crimes. So how do we marry these two truths? Marshall?
Well, I have a bit of a different view than the good doctor. I actually view the mental health issues and the addiction issues as separate issues. There's no question that both of them act on each other. There's no doubt that happens. I think one of the problems in our system, and one of the reasons why the what kind of a system that we have has become so convoluted, is that we have community-based psychiatrists attempting to treat addiction with mood-altering pharmaco interventions. And they are not correctly diagnosing and identifying substance use disorder. So they're treating the symptoms of the substance use disorder and compounding the problem. I'm sure that you would agree with that. I think that we've gotten to a point in the confluence of mental health and addiction where the system needs a bit of separation between less generalists dealing with these and more specialists who can practice recovery-oriented medicine for people who are addicted and dependent on substances, and then mental illness. And for sure, of course, there are going to be some crossover people who have both, and that's a very different specialization. But I don't think that we serve ourselves well to be smushing these two fields of practice together and expecting that people who are mental health practitioners understand how to deal with chronic neurobiological brain disorders like addiction in the same way and with the same tools that they would treat schizophrenia, or other mental illnesses.
It's interesting because we're on the one hand talking about a continuum of care where everything's coming together, but you're saying maybe we're mixing some specialties that won't achieve the best results. Would you agree, Dr. Matthew?
I would humbly disagree with that. If you look at the coroner's report in British Columbia in 2017, 52% of the people who overdosed and died that year had a mental illness. So concurrent disorders are the rule, they're not the exception. One of the big issues, though, and Marshall is right, without proper training, it's very difficult to train both. And so if you look in British Columbia, there's only 32 addiction psychiatrists in the whole province. And 13 of them work in my program. So, I mean, there's not a lot of this expertise to spread around. In the United States, addictions wasn't a recognized specialty until 2017. And it went under the American Board of Preventative Medicine. And what they said was that addictions is a subspecialty. So if you had any recognized board and training in addictions, then you could do addictions. And what that means is we need everybody in this. So we need obstetricians who are trained in addiction. We need psychiatrists who are trained in addictions. When I did my fellowship, the person who ran the methadone clinic was a hepatologist, and he combined HIV and hepatitis treatment with the methadone and had great results. So we need people from all areas and not a specific area of just addictions. I don't think we'll be able to train as many people as that, but we need whichever door that the patient comes into should be the right door. And they should be able to be directed into treatment or treated from wherever they come. So we need to make this a mandated part of medical school and residency training, no matter what kind of physician you are, if you're patient-facing, of course. And it should be part of psychiatry. And then we should also have specialists as well that can deal with the more severe cases. So I think we need all of that.
So I don't disagree with the doctor. I think we're when I say it should be separated, that of course is contingent on the fact that you don't have enough trained people, right, to do it together. And until you do, right, I think we need this. Especially the other challenge that I have is I think we got into some of this problem, with our system simply with the over medicalization of this solution. Right. This is, look, addiction is a chronic illness, right? It's not unlike diabetes or, chronic heart disease. There's a certain way that I need to live my life in order to stay healthy, just like a diabetic or somebody who, has a chronic heart condition. In the alternative, if you over-medicalize my condition, that's tantamount to me going in for a checkup and getting the paddles every time, I go in to see the doctor, when what's necessary is a recovery checkup, right? I'll just tell you a brief funny story. So I'm, probably one of the most well-known recovery advocates in the country. I have high blood pressure that I take, pills for. And I have a doctor that I've been seeing for 10 years. And the doctor's very well aware of who I am and what my history is. And I go in every time and, he takes my blood pressure and adjusts my medication, et cetera, et cetera. Not one single time has he ever asked me how my recovery's going, right? Which certainly will kill me faster than my high blood pressure. So I think that when I start talking about we've got to think differently about this, we also can't afford a psychiatrist for every addict that is out there. We just can't afford it. So even if it was indicated, we've got to have a community response, right? And addicts respond well to each other, and we've got to lean heavily on the recovery community to build that up and promote it. And there's absolutely room for medicine, and science one day may fix this, but it hasn't so far. And so my bias is more of a community peer solution with the supports of medical professionals. But I don't think that we should be expanding, or going all in on, pharmaco-interventions and psychiatry and this, that, and the other.
So, Dr. Matthew, the genesis for today's event and the concerns that people have been expressing is about disorder on the streets, the fear of violence from strangers, and the repeat offenders. So from sitting where you do in your area of medicine, what do you think the solution is?
I don't think there's any home run solution to all of this. And I agree with Marshall in that I think there has been a medicalization of the opioid crisis. I think it's been, in British Columbia, conceptualized as an opioid deficiency. So think of iron deficiency anemia. If you don't have enough iron, you give the person iron and they get cured. And I think in British Columbia, it's been conceptualized as someone doesn't have opioids. If we give them more and different types of opioids, this is going to solve it. And it seems like every intervention has gone down that path where I think we do need more supports and more things available other than just giving people medications. So what would be the solution? I think we have to start with prevention. And one model is the Icelandic model for prevention. So what they did was they engaged communities and schools, and they found folks that could be go-to places for youth who needed to seek advice. They would identify youth when they were young. So John Doe had issues with anxiety. So they could identify and treat these kids while they were in school, while they were young. Then The other thing that they did was that they provided vouchers to families, and so that the kids could engage in extracurricular activities like sports, even though their family couldn't afford it. So this provided community for them. So if John Doe had something like that, he wouldn't have to engage with folks who were using cannabis to find any sense of community. So what were the outcomes for that? When you looked at public intoxication, from 1998 to 2015, it dropped from 42% to 7%. When you look at prior month drug use, it dropped from 17% to 2%. So these are interventions that could work from a prevention point of view. Then I think we have to look at treatments. And Marshall mentioned that there's a lack of a system. So we don't know what the needs are in British Columbia. So there's a general idea that there's about 100,000 people with opioid use disorder. Where are they? Nobody knows. So we need to mine the data and figure out where folks are. And then we need to know what their comorbidities are so that we can build a system that would treat their actual needs. The next thing regarding treatment would be to make an integrated system from the beginning so that it's not silos and it's not reactionary, but that it's all built together so that it all works together so people can move from one door to another door and get all their needs met. The other thing would be the duration of treatment. So I mentioned the issue with protracted withdrawal and that this is a problem that takes months to years to solve. So not 30-day programs, we need like 9, 10, 11, 12-month programs just for the acute treatment. And especially with people who are complex with mental health and substance use disorders. And we also have to recognize that some things won't get better. So there was the hotel study that looked at folks in the downtown east side. What they found was that 95% of them had a substance use disorder. Nobody's surprised by that. 85% of them had a mental health disorder. And then 45% of them had a neurological disorder that could be diagnosed on neuroimaging. So this is brain damage. And folks aren't going to recover from that. So we have to take into account the reality of what's out there. Who are these patients? So after the acute treatment, there needs to be long-term recovery, as Marshall was mentioning, and a system in place where people can go. One of the big missing factors, and it is an element, and I know you talked about it, but we need housing. And not just any housing, because most of the housing for these folks are housing where other people are using drugs. We need housing where people are not using drugs. We also have to have things for people to do. So if you look at the Portugal model, they incentivize vocational training so that people can get jobs, so that they subsidize employers so that they could hire folks at a lower wage to incentivize people who are in recovery so that they can learn skills and get into the employment market so that they have a purpose and something to do during the day. And then also, as Marshall mentioned, we need to have an off-ramp for the correctional system that's formal and where people can go, because a lot of these folks are the ones that are going to get into this revolving door. So we need to do something after they leave the correctional system. We need objective measurements for all of these programs, and we need incentives for people to join these programs. So if there was a system in place, I think this would be something of what it would look like. I'm sure there's holes and things I've missed, but that'd be the broad outlines.
So if we were fortunate enough to have the leadership and the system that you talked about, Marshall, and had it in place, and we had a continuum of care, where are the intervention points that are likely to be most successful? Because I'm sure when you were on the streets, you had many offers that please come into, we've got help for you, and you refused until one final point that a policeman convinced you. How did that
Well,
happen?
look, addiction is about continued use despite consequences. And so addicts will continue to use until the consequences of their using outweigh the benefits, right? And so once you have a system where there are at least, I mean, there are no consequences right now. None. We've removed all the consequences. And we've tried to make smooth and, create environments where people, can use safely and do all of this stuff. So we've taken away the main driver, the main sort of impetus for change in the individual, which is to, receive consequences. I'm not suggesting that we go around inducing consequences. There's enough of those organically, but we shouldn't be removing those. Where are the points of intervention? That is a really good question. So K through 12, like I explained, the Icelandic model, we follow the Icelandic model in Alberta. Get into those classrooms, right? We have got to start identifying those kids early and supporting them and getting them on the right track. That includes things like school nutrition, after school play, all of these holistic things that we're in like 60 schools now in Alberta. It's very cool. Corrections. Go all in on corrections, right? 40% of people who fatally overdose have been in custody in a period of time prior to their death. So what are you waiting for? You know where they are. You already have the building. You already have the beds. You don't need any capital. They're all pooled up in one place. Get some therapists in there and get to work, right? Like build great treatment programs inside your correctional centers. They're a thing of beauty. And if you ever have the honor to go and sit with those women and men who are in a correctional center, committed to a treatment program, and listen, to what they have to say, it's spectacular. You can't help but want to cheer them on. Police are another one. We have to give the police more tools than just handcuffs to solve this. In Alberta, we created the virtual opioid dependency program. It's world class. You can have a constable in the back of their car, call the VODP, hand the phone or speakerphone to the individual and get them started on Sublocade right now. Right? Not tomorrow, not a month from now, not fill out these forms right now. I'll take you to the pharmacy and we'll get you on that. Police, corrections, treatment availability, schools. That's where you intervene.
I think we've got a long way to go in BC, sadly. So, Dr. Matthew, as a concluding thought, what would you say the first step you'd like to see towards moving towards a better continuing care system?
I mean, it's not the most glamorous thing, but I think we need to figure out what the need is. We need to get the data. We need to figure out who has what problems where, because until we figure that out, we don't know what to build. It's just haphazard, and we're hoping that we're building the right thing in the right place. We need the data first.
I would respond to that by saying data is lovely. And necessary, and for policy and decision makers, data and science is great, but it isn't the only thing, and you should not wait for it to catch up to you. We rely heavily on high quality science and data in developing the Alberta model, but equally as a policymaker, I have to weigh what the data and the science says with the values and the goals of the community, right? I have to balance those things. And it's not all about what the science says, follow the community's vision and goals as well. You will intuitively know what to do. And we know you can take some leads, as we did. We were in a similar position. We didn't know everything about where we wanted to go. We took off around the world to scour the best practices, and we took back the best parts of the world's knowledge in to develop our model. And what that told us was, get to work building facilities, build them this way. They're in the country, they're long-term, they look like this, intervene with the police, intervene in corrections, intervene in schools. And so we got busy doing that. And data, I mean, we're very big on data, Dr. Matthews. Core.
On that note,
Yeah. All right. All right.
thank you both. We appreciate your comments and some different opinions here on how we go forward. And thank everybody here. You're here because you care. And thank you, SOS, for pulling this together.
Thank you very much. Thank you very much, Carol, for doing a great job. And to our panelists, we were missing one panelist. We're not sure what happened to Dr. Azar, but you guys filled it in beautifully, and we knew that Carol would be able to handle that. So thank you very much.